We released the October issue of Health Affairs focused on violence and health. Really proud of this issue, the first time we've ever devoted an entire issue of Health Affairs to the topic of violence. We often hear that violence is a public health issue, and it certainly is that. We're a journal of public policy and health policy, and so for us, we wanted to expand the conversation around violence to include elements that we tend to focus on in the journal. Health systems and how violence intersects with the role that health systems and healthcare providers play. The financial and human burden of violence and the many different ways it intersects with the healthcare system. But particularly a focus on policy. And one of the things that I find exciting about the issue is that in addition to a lot of documentation of the challenges we face and the scale of violence and its intersection with the healthcare sector, there's also a lot of really interesting work going on from a policy side, both around prevention and around response to violence. And as a policy journal, we like to keep our focus on not just documenting problems, but figuring out what the next steps are in addressing them. We were able to prepare the issue with support from the Blue Shield of California Foundation and the California Wellness Foundation. Thank you both for your support, and this event also, of course, is possible because of their support. So the way, I will say when we do a thematic issue, we typically have an event in Washington, D.C. where we invite all the authors. We did have that event. It was terrific. Again, if you want sort of the best half-day summary of what's in the journal, that's archived on our website. This is a slightly different session, and so I just want to give you a sense of what to expect for the morning. We did ask a handful of the authors to come and present. These are not all the articles in the issue by any stretch of the imagination, but they're ones that I think capture some of the breadth of what we did cover, and I think they set the stage for the conversation that we want to have today. Because of the critical role that communities play in both experiencing violence and also responding to violence, we're going to have a presentation after that that gives you a little bit more of an on-the-ground feel of how communities are responding to these issues. And then we have a policy panel and a number of different perspectives on how folks are, again, are both working on the prevention side and on the intervention side to address the issues that we confront. For each of these, there will be presentations, there will be time for Q&A, and as I say, because of the time we have today, I hope you all will engage in the conversation. So as we get started, I just want to give a few minutes to the CEOs of the two foundations that were able to provide the support for us. Let me first introduce to you Ray Baxter, President and CEO of the Blue Shield of California Foundation. I knew him as Senior Vice President for Community Benefit at Kaiser, formerly head of the San Francisco Department of Health and New York City, and lots of other terrific accomplishments. Ray? And I don't know if, does this work? I think we're going to still have to work with this one. So.
Try this for, no. Use this one? Okay, thank you. Alan, thank you so much, and thank you again for facilitating and assembling this impressive body of work that's captured in the journal. I'd also like to welcome the Health Affairs team to California, another beautiful day here in paradise. I'm honored to be here as the CEO of the Blue Shield of California Foundation. We've supported Health Affairs for at least 10 years, and we were especially pleased to have a role in supporting this important issue of Health Affairs, which I gather began during, seed was planted for this during a panel discussion about 3 years ago at Grant Makers in Health, so we are really happy to see it realized. This represents a real contribution to our collective work on and understanding of violence. So it is a special privilege to be joined today by some of the authors, by a number of our foundation's partners and good colleagues at this meeting. Violence remains an epidemic that threatens the strength of our communities, the health of our families, and the promise of too many futures. Alan mentioned the convening 2 weeks ago where we had a number of authors collected in Washington, D.C. I want to mention 5 things that really jumped out at me that day and that I had not fully appreciated until we went through the course of the discussions during that day. The first is how far we still have to go to build a body of knowledge, a formidable cadre of researchers in a field of practice in this area of violence. Despite the extraordinary contributions of the researchers who are represented in this issue, they are far too few and seriously under-resourced. There is no other major cause of injury and death for Americans that has so meager an investment from the government and from philanthropy. The second thing that jumped out at me is how profoundly gender and race shape the forms that violence can take and who the perpetrators and victims of violence are. Only one of the articles in this issue focuses directly on domestic violence, several others on race and place. But the issues of race, of gender, and inequity run through almost every article in this volume once you get past the title of the article. If you haven't read them all, I urge you to read them carefully and pay attention to that. The third thing that jumped out at me that day is that gun violence and mass shootings tend to dominate our national dialogue about violence, along with a very confusing and stigmatizing discussion of mental illness. But guns are not the sole issue worthy of our attention. And again, this issue dramatizes that. Guns make violence lethal in the moment. Access to a gun makes it 5 times more likely that a woman will be killed by her abusive partner. But there is also lethality over the long term in all forms of violence. Some of it is rooted in exposure a generation earlier, and some of its health effects show up in the form of life-threatening illness a generation later. Violence is not just inflicted on others. Suicide and self-injury are as important as murder and assault, as you will see from some of the articles in this issue. Violence is shaped by social norms and conditions, which means it must be approached at a community and a policy level, not only at an individual level. And finally, prevention of violence is possible. It's appropriate that this issue of health affairs has come out in October, which is Domestic Violence Awareness Month. It unifies the 2 aims of our mission as a foundation, to make California the healthiest state and to end domestic violence. So once again, I'd like to thank all of the researchers who were willing to explore this critical intersection. Your work in this underexplored area is giving us a much richer understanding of the deeply rooted and widespread impact of violence on individuals and on communities. Whether we are talking about violence in the home or gun violence in a neighborhood, these are not issues and events that can be addressed in isolation. Violence creates cumulative harm that spreads through generations and significantly impacts health and well-being, both directly and indirectly. Until we finally understand and fully understand the connections and consequences of violence, we cannot stop this self-perpetuating cycle. Blue Shield of California Foundation has contributed more than $100 million to address and prevent domestic violence in California. Some of that funding has gone to our life course research, which sheds new light on risk factors across the lifespan of victims and perpetrators of domestic violence. A 2017 survey that we commissioned found that 58% of Californians have been touched by domestic violence, either as a victim, an abuser, or through a close friend or family member. We hope that the research from this issue of health affairs and this discussion will be a starting point for more and ongoing research that examines the critical intersection of all forms of violence and health. And we are determined that gender not be left out of that equation. Thank you again for being here. I look forward to the conversation ahead. And now I have the privilege of turning over the podium to Judy Belk, President and CEO of the California Wellness Foundation, who has been such a leader through that organization on the issue of violence. Judy.
I think this is working now. Let's give it a try. Yep.
Can you hear me? That's usually not a problem. Thank you, Ray. And thank you, Alan. Ray, we have really been honored to be a partner with the Blue Shield Foundation, not only in underwriting this issue, but also our work in the Hope and Heal Fund, which is a statewide collaboration of other funders, and our work in just providing access to care. I just got back from vacation, and this was part of my vacation reading. Alan, I want to thank you, because I think you and your researchers, those who are here today, Professor Tung, Professor Laqueur, Professor Woods-Jaeger, and Professor Riewerts, you've created a public service in this publication, and one that kind of reaffirmed my own personal narrative and stories that we have heard all over California, because violence is indeed a public health issue. I turned on the radio this morning and heard that yet another police officer in New York, the 10th this year, has committed suicide. I live in Hollywood, in a very normally peaceful neighborhood, and 2 years ago, we experienced a suicide in that neighborhood by a neighbor had access to a firearm. We have talked to many young people. The hypervigilance that was noted really touched a chord to me, and the link to high blood pressure. As someone who has experienced violence through the loss of a sister to gun violence, loss to a cousin of gun violence, and I've seen how that impacted the community that I grew up in Alexandria, Virginia, and how it has impacted my family, how it has continued to impact me. It's a reminder that the long-term effects of violence are with us. And so in many ways, this report, the research that you have provided, was reaffirming. It was reaffirming about the linkage and the work that the California Wellness Foundation has done for over 25 years ago, when California Wellness addressed some of the research that was coming out of Harvard over 25 years ago about violence as a public health issue. It was unusual. I was just starting out in the field of philanthropy, and there was even pushback in philanthropy at that time. What was the Public Health Foundation doing talking about violence? So we have come a long way. And our commitment is that we will do everything we can to ensure that this research and this material gets in the hands of public policy leaders, our community partners, and others. I started this morning by waking up my husband and said, who's a physician, you need to read this. And so I really do want to thank you for your efforts. I also want to acknowledge that there has been success made, and California has played a role in that, and it's really taken community partners, it's taken researchers, and it's taken government. We're really proud that we have the first state-supported Firearms Research Center at UC Davis with Garen Wintemute, who I know was a senior advisor to this issue. We are really thrilled that the County of Los Angeles has launched an Office of Violence Prevention in the Public Health Department. And we are pleased that so many community coalition groups that we support have continued to raise this awareness. Again, we want to thank Health Affairs. This is a timeless issue. It will get in the hands of community leaders and policy leaders. We are really delighted to be part of today's presentation, and we look really forward to learning. But you have definitely provided a community service, and we thank you for that.
Thank you, Judy, and thank you, Ray. Since you both made comments, I will just say when we've done audience research, we find that people look to health affairs as an agenda-setting place in health policy, and so it was a strong statement, one that I was proud to be a part of, for us to say this is a topic that warrants an entire issue. So we couldn't have done it without your support, but we're also really proud of the work and putting it in the field. I'd ask my first panelists to come up. I think most of you are sitting over here. And we'll just move right into a discussion of the content here. As I mentioned, in this first session, you'll be hearing about papers that were in the issue. And not all of them, but enough, I think, to give you a good feel for what we were covering. Liz Tung is a researcher and practicing internist in the section of general internal medicine at the University of Chicago. Hannah Laqueur is assistant professor in the Department of Emergency Medicine at UC Davis. Briana Woods-Jaeger, assistant professor in the Department of Behavioral Sciences and Health Education at Emory University. And Bo Riewerts, chief of pediatrics with Kaiser Permanente Southern California, who chairs their work group on firearm injury prevention. So I will ask Liz, you've done this before, you're a pro, so why don't you kick us off?
All right, so it looks like the PowerPoint is actually over there. Let me see if this works. Oh. Okay, great. All right, so good morning, everyone. Thank you so much for being here. I'm really honored to present some of the findings from our study on the Chicago Violence, Neighborhoods, and Health Study. I'll be presenting two papers from this study today, and the first is about social isolation, loneliness, and violence exposure. And this issue of social isolation began to catch my attention several years ago, around 2014 when I started my clinical practice as an internist on the south side of Chicago. I had a number of patients telling me that they don't really get out of the house much because they're afraid to go out sometimes. And I was talking to one woman in particular about maybe having some family members take her out to run errands instead. But she told me that she was even afraid to have her son come visit her and said that it was because he's a young black man with a bright future. And she's terrified that being back on our block means he could be mistaken for somebody else and either get shot by a gang member or shot by police. So instead of asking him for help, she tells him that she's doing just fine, even though she's been really struggling with all of her health issues on her own. So these stories really began to accumulate in my clinic, and I started digging into this issue more and more. The late and great John Cacioppo was really a pioneer, and some might say founding father of loneliness research, and he theorized that a hostile or violent social environment can erode the very foundation of social connectivity, which requires trust, security, and the feeling of being meaningfully connected. And so I just want to do some quick definitions to get everybody on the same page. Social isolation refers to the absence of social contacts or opportunities. Some measures of this could be living alone, having few social contacts, or having infrequent social contacts. Loneliness, on the other hand, refers to the subjective experience of being left out or excluded. And this could be true even when social contacts and opportunities are plentiful. This is a topic that has gotten a lot of attention recently. A number of public health officials were calling loneliness a health epidemic. Loneliness is reportedly so prevalent in the UK that Parliament has actually appointed a minister for loneliness to address the issue. And all of this matters a great deal because loneliness has been shown to be a key predictor of mortality, even proportional to traditional clinical risk factors like smoking. Some studies have estimated that being lonely is comparable to smoking about 15 cigarettes per day, which is pretty astounding if you think about risk factors. So while there are a number of narratives and stories that highlight a link between violence and isolation, very few studies have actually quantified these associations, and none have used a broad subset of social isolation measures. So to do this, we conducted hour-long in-person surveys with over 500 adults from 2 epicenters of violent crime in Chicago. The surveys included an in-depth social network assessment that included social network characteristics, living arrangements, social participation in community activities, perceptions of social support, and also loneliness, that subjective experience of feeling alone. And what we found was that exposure to violence was linked to higher social isolation and loneliness. Specifically, we saw a reduction in the frequency of contact with network confidants. These are the people that you confide in and share important things with. We also saw a reduction in perceived social support from friends. And notably, we saw a rather large increase in loneliness. Loneliness was actually twice as high in our sample of older adults living in high-crime neighborhoods compared to older adults in the general U.S. population. And when we took a closer look at loneliness by specific violence types, we actually saw that loneliness increased in a graded fashion by the severity of violence. So we get higher loneliness starting from indirect exposure to direct exposure, and finally to exposure with PTSD. And you can actually see at the bottom here that we saw over 3 times higher odds of loneliness in those screening positive for PTSD. So there is an incredibly strong link between trauma and loneliness. But what I found particularly interesting was that even with indirect exposure, as a witness, friend, or family member, we see almost 2 times higher odds of loneliness, which means that violence can have these rippling effects, not just on individuals who are directly targeted, but on their entire broader community as well. So while many public health and policy leaders are calling loneliness a health epidemic, others are actually somewhat pushing back on this. Eric Kleinenberg wrote a really excellent op-ed for the New York Times that said, overstating the problem can make it harder to make sure we're focusing on the people who need help the most. We've identified that people affected by violence are at higher risk for loneliness, which suggests that one solution to loneliness may be violence reduction. But importantly, we also need to target our solutions to those communities that are routinely affected by violence to ensure equal access to the social and medical supports that are needed. Okay, and so in our second study, from the same larger Chicago study, we looked at exposure to violence and hypervigilance. Hypervigilance is another consequence of violence that has really emerged in patient stories and narratives that we've been hearing. And it's defined as a state of heightened awareness and watchfulness, even when the immediate risk of danger is low. This has been studied extensively in veteran populations and represents one of 4 major symptom clusters for PTSD. And it's notable because it's been associated with a number of adverse consequences. Specifically, we can see upregulation of the fight or flight response, as well as poor emotional regulation and cognitive impairment. The way that some of this has played out in psychiatric experiments is that participants might be shown a trigger image or a word like attack, and then they might be shown the word blue in green font. And in hypervigilant individuals, they actually have difficulty correctly identifying the word as blue. This is known as the emotional Stroop task. For this study, in addition to looking at community violence, which is violence between community members, we also looked at police violence, which is violence between community members and law enforcement. And we wanted to look at police violence specifically because recently there's been growing awareness of police-involved shootings of Black civilians. Researchers have estimated that in a single year between 2015 and 2016, more than 100,000 years of life were lost to police violence in the US. So our primary objective was to quantify exposure to both community and police violence and their associations with hypervigilance. And as a secondary objective, we wanted to look at the relationship between hypervigilance and physical health. We were especially interested in blood pressure because of the theoretical linkages between hypervigilance and that fight or flight response. And so we measured exposure to neighborhood violence using the brief trauma questionnaire. Community violence included direct victimization, but also witnessing or having a close friend or family member who was killed. The same criteria were used for police violence. And then we also asked participants if they had ever been involved in a police stop that escalated to feeling like their life was seriously threatened. And these were classified as traumatic police stops based on DSM-5 criteria. Hypervigilance was measured using the brief hypervigilance scale, another validated tool asking about daily watchfulness, emergency planning, scanning a person's surroundings, and chronic fear. And finally, we took health outcomes, obesity, and hypertension from the electronic health record at the time of interview to look at our physical health outcomes. And what we found in this study was that almost 60% of our sample reported exposure to community violence of some form, either as a victim, witness, friend, or family member. When looking at linkages between the type of violence and hypervigilance on a 100-point scale, we see that community violence was associated with roughly 6-point higher hypervigilance score. The overall rate of exposure to police violence was roughly 30% in our sample, which is quite high, or at least we thought it was. But we saw a 10-point higher hypervigilance score with exposure to police violence. And finally, 10% of our sample had exposure to a traumatic police stop in which they believed that their life was seriously threatened or in danger. And for this type of exposure, we saw 20 more points on the hypervigilance scale, the highest score that we saw for any subgroup. For our secondary outcome, we found that high levels of hypervigilance were associated with higher blood pressure by about 9 millimeters mercury, which is actually a fairly large effect size. As a point of comparison, studies have shown that for middle-aged and older adults, an increase of about 10 millimeters mercury is associated with 50% greater risk of death from heart disease or stroke. Okay, whoops. So in conclusion, exposure to neighborhood violence, especially involving law enforcement, was associated with higher hypervigilance. This was highest for those exposed to a traumatic police stop, and hypervigilance was significantly linked to higher blood pressure in our sample. Ultimately, growing awareness of hypervigilance will help to inform healthcare responses to violence. For example, our team's exploring best practices to screen for violence in healthcare settings. We're also working on expansion of trauma-informed care, which is a framework for understanding, recognizing, and responding to the multidimensional effects of trauma. It was initially implemented in mental health spaces, but we're starting to implement these practices in primary care, inpatient trauma units, and also the emergency room. And finally, we think that a better understanding of hypervigilance will also be helpful for informing police practice reform. Recently, I was listening to a radio segment on Chicago's NPR, and the segment was on The Talk, which is a conversation that Black parents have with their children about engaging with and surviving police encounters. And as I was listening to Black parents describe the conversations that they have with their kids, it really struck me that much of the conversation actually revolves around managing the hypervigilance of police officers. And these communities have actually been training their children on how to do this for decades. But the reciprocal is often not true. Historically, police officers have not been trained on how to manage the hypervigilance and trauma of community members. And so we think that the widespread adoption of trauma-informed policing, which we view as a health policy issue, is really critical as we think about police reform in this country. Trauma-informed policing equips officers with a public health framework and tangible skills so that when engaging with community members, highly traumatized or hypervigilant individuals are not policed in a way that leads to further escalation of violence and ultimately re-traumatization. Thanks so much for your time. Please feel free to contact me via email if you have any questions or comments, and I look forward to the Q&A.
Hi, thank you very much. Good morning. My name is Hannah Laqueur, and I'm looking forward to talking to you today about our study that looked at alcohol-related crimes and risk of arrest for intimate partner violence among handgun purchasers in California. Well, and that's it. Thanks, guys.
Oh, maybe it's...
That's okay. Well, I should just...
Should Briana go first, and then maybe they can...
I can also just talk
Fix them?
without slides.
If yours are up, do you mind? Why don't we do that and we'll get yours
Okay.
loaded up? Sorry about
I'll be
that.
back.
Switch. Yeah. Surprise, you're up.
Good morning. Well, I want to thank Health Affairs again for this special issue and this opportunity to share some of our work. I want to acknowledge my co-authors, Jeanette Berkeley-Patton, Caitlin Piper, Paige O'Connor, Tiffany Renfro, and Kelsey Christensen, as well as the Robert Wood Johnson Foundation, which has funded our work through the Interdisciplinary Research Leaders Program and really given us a unique opportunity to partner with youth who've experienced community violence as we seek to build a cross-sector intervention to promote resilience. I also want to acknowledge our community partner youth ambassadors and our community action board, which is comprised of youth and community stakeholders who are guiding our research at every step. Okay, so just to give a little background for our study, we know that youth exposed to community violence are at increased risk for a number of negative health outcomes, including physical and mental health. And the African American youth experience higher rates of community violence exposure, as well as severe forms of community violence that results in violent-related injuries and homicides. Homicide is actually the leading cause of death for this age group. And so what we've noticed is that rarely have African American youth really been engaged to really understand what their perceptions are regarding the issue and what we should be doing in terms of strategies we can implement to mitigate the impacts of community violence exposure. And so what we were really interested in doing was partnering with African American youth who have this lived experience of community violence exposure to really understand what solutions we can develop that are going to be responsive to their lived experience and build on their assets and strengths. So we, in terms of our focus, we wanted to start with a qualitative study to allow us to explore some of the nuanced issues around community violence exposure and really gain insight into youth experiences and the aftermath of community violence exposure. So we're really focused on after they experience community violence, what is their experience? So our aims were to better understand African American youth perceptions regarding social and structural factors that affect the experience of community violence, to identify strategies to promote health and well-being among African American youth after community violence exposure, and to incorporate the lived experience of African American youth who've been exposed to community violence in the development of policy and system-level interventions to promote health. So we conducted 5 focus groups with 39 African American youth who have been exposed to community violence in Kansas City, Missouri. We recruited youth ages 13 through 18, and the average age of our participants was 16. We recruited specifically for community violence exposure, but youth in our study reported an average adverse childhood experience score of 6. And so that indicates they were exposed to numerous other trauma and adversities in addition to community violence exposure. So in terms of our themes, during our focus group, okay, well, I'll kind of keep going, and maybe it'll get pulled back online. But during our focus group discussions, participants consistently expressed the view that the response of multiple sectors, and in particular law enforcement and schools, was inadequate to address their experiences of community violence. Let me see if I can get back so you all can. Okay, there we go. Okay, so for example, in regards to law enforcement, one youth shared, at first police don't even be there on time. A little boy died because the police canceled or hung up the phone, like they don't get there early enough. Participants also described schools' responses to violence as limited and often not responsive to the concerns brought forth by youth. And they attributed this largely to school personnel not understanding the complex nature of community violence and the consequences of community violence. So one youth shared with us, they have all these signs around school, no bullying, no bullying. We telling y'all these kids, some of these kids are suicidal, and you all doing nothing about it. And then finally, youth described how a lack of resources within their schools and communities resulted in difficulties coping with community violence exposure. One youth shared, we really don't have no places that can help. It's always like somebody that's gonna die in the beginning of the school year. Everybody really ain't gonna know how to cope about it. So overall, this theme highlights the general consensus among our participants that a more proactive response was needed from adults in multiple sectors to address their needs related to community violence exposure. Our second theme really centered around youth experiences of racial discrimination. We heard frequently in our focus group discussions about the impact of racial discrimination and how it chips away at youth resilience over time, particularly as they're trying to cope with community violence exposure. Youth spoke specifically about their exposure to the trauma of police violence. One youth shared, there's not a law that says it's okay to kill a black man in a car, but we see all these white cops killing black men and it's okay. Participants also explained how stereotypes of black youth resulted in the experiences of being profiled and misjudged. One youth described this sharing, and that kind of irritates me when I want to go somewhere and the police is just all up on me, trying to see what I'm doing. I just came to chill and have a good time like everybody else is doing, and I'm the one that's getting stopped, and I'm the one that's getting questioned, and I don't have nothing to do with it. Another youth shared a similar experience in the school setting, stating, so the white principal, she took my backpack and she went through it. For what? I don't know. I was the only black kid in class that day, and so she looked in my backpack. Participants expressed that these experiences were frequent and painful and reinforced the feeling among many African American youth that adults and society at large don't understand them or care about them. So participants clearly outlined recommendations to address these barriers. They emphasized the importance of focusing on mitigating racism and discrimination across sectors, and we were focused primarily on healthcare, law enforcement, education, and the faith sectors. They also talked about the need to increase resources specifically to mental health, for mental health throughout the community, and emphasize integrating these into important community institutions like schools. Safety was a top priority for youth in our study, and they indicated that there was a need for a greater investment in neighborhoods and community infrastructure to promote safe spaces. And finally, one of our nuanced findings was, although participants expressed distrust due to police profiling and violence, they also recognized the important role of police in promoting community safety and really wanted to find more opportunities to partner and build relationships with police. They talked about trust being critical for this and that greater transparency and accountability would build this trust. So African American youth exposed to community violence are asking for support to promote their health and well-being, and they've outlined a clear action plan with priorities in order to address this that has direct policy and practice implications. These include implementing evidence-based training and policies that recognize and reduce the harmful impacts of racial bias, supporting school-based mental health through leveraging current school safety and mental health in schools initiatives to integrate more mental health resources into schools specifically focused on community violence exposure, increasing safety for youth through evidence-based policies that improve neighborhoods such as greening, building repair, and enforcing restrictions on negative influences like liquor stores, and cross-sector collaboration. So really thinking about how to bring sectors together, in particular police, schools, and mental health, to have more trauma-informed responses, as was mentioned in the previous presentation. So I just want to end with the words of one of our youth participants. We all know that violence and racism and colorism is happening, but if something was actually put into plan for people to come together, we actually need people who are motivated to try and fix it. Thank you.
So I can just close. There we go. Okay, thank you. Towards them. Got it. Okay. Hold on. Towards them? Sorry. A lot of technical difficulties. There we go. Okay, sorry about that. So again, talking about our paper looking at DUI convictions and risk of arrest for intimate partner violence. So there are some well-established risk factors for intimate partner violence. Research has clearly shown that alcohol use, particularly heavy use and binge drinking, contributes to the risk and severity of violence generally and intimate partner violence specifically. Studies suggest that over a third of abusive partners have significant alcohol problems, and female victims of intimate partner violence report that their partner was drinking before an assault in about 30% of events. Firearms are also a well-established contributor to the risk and the severity of intimate partner violence. So as we heard in the opening remarks, studies suggest that victims of intimate partner violence are more than 5 times as likely to be killed if the perpetrator has access to a firearm. And over half of intimate partner homicides in the United States are committed with firearms. And then finally, there's also some evidence from survey data to suggest that firearm owners may be more likely to engage in risky drinking behavior. So while we know about these risk factors, there's been little research looking at this nexus of risk factors, that is, firearm ownership, risky drinking, and then risk of intimate partner violence. And so that's what we do in this study, looking at the specific question of whether a DUI conviction, an indicator of risky drinking, is a marker of risk for intimate partner violence among handgun purchasers in California. Oh, look at that. Okay. Thank you. And this question also has direct policy relevance. So a key overarching firearm violence prevention strategy in the United States is to restrict access of firearms to individuals deemed high risk. Federal prohibitions include restrictions on those with felony convictions, as well as misdemeanor domestic violence convictions, restraining orders, but there's no federal prohibition on those who misuse alcohol. A number of states have enacted some sort of regulation on those who use alcohol, the majority being a restriction on purchase or use while intoxicated, although in many of these cases there isn't specific criteria to sort of operationalize these regulations, such as a blood alcohol content level. But a few jurisdictions have operationalized alcohol misuse by restricting access among those with DUI convictions. And California recently had a bill, SB 55, that would have prohibited purchase and possession among those who had multiple DUI convictions. It ended up being stalled in committee, but its proponent, Hannah Beth Jackson, plans to reintroduce it again next year. So our study also speaks to this specific potential regulation. Okay, this guy, look at that. Okay, our study sample included everyone aged 21 to 49 that legally purchased a handgun in California in the year 2001. And then we identified if and when purchasers were charged with crimes from the time that they were able to pick up their handgun in 2001 until the end of 2013, or earlier if they left the state or died. And this graph here shows the percent that were arrested over this follow-up period broken down by criminal history. So the bars on the left show you that 6% of those that had a DUI conviction at the time of their purchase were subsequently arrested for an intimate partner violence offense sometime during follow-up. And this compares to 1% who had no criminal history at the time of their purchase, and 5% who had some criminal history that wasn't a DUI. And then the other bars here show you just any violent crime broadly, then violent index crime, so murder, robbery, aggravated assault, rape, and then firearm-related violent crime. And then here are the results from our Cox Regression Models. So after adjusting for individual and community level factors, we find that the association between a DUI conviction and subsequent arrest for an IPV is still present. We estimate close to 3 times the risk for an intimate partner violence arrest among those who had a prior DUI and no other criminal history compared to those who had no criminal history at the time of purchase. And we find similar hazard ratios for other violent crimes, violent index crime and firearm violent crime. Notably, among handgun purchasers who were arrested for any violent offense during this follow-up period, intimate partner violence, specifically battery of a spouse or partner, was the most common offense. And we found this was actually true both among those who had a DUI conviction at the time of purchase and those who had no criminal history. Okay, so just some concluding thoughts. Available evidence suggests that limiting firearm access to individuals deemed high risk can reduce the incidence of violent activity among those persons whose access was restricted. And so comparable benefits may arise from similar restrictions on persons convicted of DUI crimes. Our study doesn't yet provide causal evidence that restricting access among this group would reduce violence, but we do provide evidence that DUI is indeed a risk factor, and we provide a quantification of that risk. And then a final point when we consider potential policy impact. At least here in California, our study indicates that a measure such as SB 55 that I mentioned earlier would actually involve a relatively small number of people. So among our cohort of handgun purchasers, 1.9%, about 1,500, had a DUI at the time of purchase, and far fewer had more than one. So it would likely be hard to detect a population-level effect if one exists. At the same time, it does have this potential to have a specific effect and avert meaningful numbers of acts of violence and intimate partner violence specifically. And also may have important symbolic import, signaling an intolerance of mixing alcohol misuse, which we know to be a risk factor for violence generally and intimate partner violence, and firearms. So thank you, and look forward to questions later.
There we go. So thank you very much for this opportunity to speak at this forum today. I am a pediatrician who has devoted a long career as a leader at Kaiser Permanente, and I have spent much of my career preventing illness and injury to the nearly 1 million children that we care for in our organization in Southern California. I do want to take a moment to thank my alma mater, med school alma mater, USC, for letting us host this event in this beautiful place. Although I did go to UC Davis, so I sort of cross over in both places. Early in my career, nearly 20 years ago, I did help to lead the implementation of our electronic health record at Kaiser Permanente. And at that time, we included questions that were asked of every parent on whether they safely stored guns in their home. This was not about their Second Amendment rights. It was simply our concern for the safety and welfare of our patients. Despite your political persuasion or passion about firearms, we are simply here today to talk about how violence is affecting the healthcare sector in our country and what we can do to make lives better. Many of my comments today are summarized in the article written by my Kaiser Permanente colleagues David Grossman and Bashara Shoker in this month's issue of Health Affairs. And as been mentioned by many, this is clearly a very important topic. Recently, Kaiser Permanente put together a task force of passionate nurses and physicians like myself to better understand how our clinicians can more effectively address and hopefully prevent unnecessary firearm injuries, whether they are due to assault or suicide or by an unintended accident. I am thrilled to be leading that task force. Now, this new role for me is right in line with my lifelong quest to make sure that children and teens are safe from unnecessary harm and injury. Before we discuss the impact of violence on hospitals and health systems, we need to also recognize the enormous burden of firearm injuries on victims, survivors, and families in our country. Health systems are a key stakeholder in the efforts to stem the loss of life and disability from firearm injury. Physicians, nurses, and ancillary staff not only see the victims of violence, but also provide care to those who survive a firearm injury. Research tells us that healthcare workers can play a central role in reducing and mitigating injury from firearms. Let's start with the impact to care. There are preventable events that lead to a huge consumption of resources. In a single year, an estimated $8.7 billion is spent on direct medical care alone. A sizable proportion of those dollars are spent on people who eventually die, but there are also many people who die before they even interact with the healthcare system. Violence occurs disproportionately to people who are uninsured or underinsured, which adds to the burden and financial stresses on hospitals and other healthcare facilities. Since the inception of the Medicaid expansion programs, there has been a decrease in some of this financial impact on the uninsured in hospitals as their injuries are more likely to be a covered benefit. Now, the impact to the healthcare sector is not just about adding to patient volume and complexity. The healthcare institution itself is a relatively dangerous place to work compared to other workplaces and occupations. According to OSHA, the rate of occupational injury that leads to absenteeism is fourfold higher among healthcare workers compared to other occupations combined. The healthcare workers are at risk in most sectors of the health system, starting all the way from the EMS system who responds to an event all the way to the eventual rehab that may take place. A recent national poll of ER physicians found that half of them reported being a victim of an assault at work in the past, and many of them have been the victim many times. Workplace violence has major consequences for the victim as well as their family. There are impacts at the worksite as well, leading to higher rates of absenteeism, reduced morale, and turnover. I think we're missing a slide. Oh well. I will continue on without the last slide. There are a number of potential roles that healthcare systems can play to prevent violent injuries and suicide. We need to move upstream and look for opportunities to improve screening that could better reduce the effects of firearm injuries. As we've heard from many of the presentations, and you will read in the journal, we need better management of depression. We need to recognize the risk of alcohol and its effects on intimate partner violence and other injuries. We need to reduce intimate partner violence. We need to implement improved hospital-based and violence intervention programs. These are just a few of the areas where we can do better. In our organization, pediatricians for years have been screening new mothers for postpartum depression, and we've also been screening teens for depression. This has been in line with established guidelines. We also screen for IPV with our obstetricians and gynecologists, but clearly we are a long way even in our organization of addressing these important problems. We need worksite interventions with improved guidelines, policies, and training of our health care providers in our systems. We need better community-based efforts such as building better community partnerships, focus on secondary prevention of violence through disrupting the victim-perpetrator cycle, and many others. Most of these areas, as you've read in these articles, they're in very desperate need of increased research dollars and attention. So thank you very much. I look forward to your discussion and any questions you may have. And sorry about the last slide.
Thank you all, and for rolling with our slightly disruptive challenges. Let me just ask two questions. One directed more at Liz and Briana, the other more at Hannah and Bo, but feel free to jump in as you see appropriate. One of the things Ray said at the outset, and there's a whole paper that we didn't present today about the very low level of particularly government funding for research in this area. Both of Liz and Briana, both of you in your work spoke to and listened to people in the field who are experiencing violence and affected by it. And as I think about when the research enterprise develops in an area, that often isn't where we start. We sort of start with big data sets and analyzing spreadsheets, and then finally someone's like, oh, we need to actually talk to people. So I wonder if you could each sort of weigh in on where you would envision going next with the engagement, the community engagement work that you've done. I'd say, imagine you had more funding, but I don't really mean this as a financial issue. You've uncovered some issues. Where would you go next in trying to understand how best to interpret and respond to these issues based on your interactions with folks in the community?
So for us, can you all hear me? Okay. That was the first phase of our work. So we wanted, again, to start with qualitative to really look at what were the experiences that we could be prioritizing, because there's so many different ways that you can approach this issue. And we wanted to hear from youth that have lived through it, because they would be the experts to really know what was needed. And so the next phase, what we did was a community-wide survey. So we took those findings and we did a survey in the community larger, and we actually did it with providers as well as with youth to really hone in on, okay, here are all the strategies that were discussed, here were the priorities, what can we do that's going to be feasible and also have impact, and then what's currently happening. So not wanting to reinvent the wheel, but really wanting to form those partnerships. So that's where we're at now in terms of really trying to bring folks together that are already working on this issue, but really galvanize them around priorities that were informed by youth. And that's where we are currently. But I think in terms of your question more broadly, I do think you're right. Often we come at it from a different angle, and for certain issues, particularly around health disparities that have been so persistent for generations, we need new solutions. And so really asking people that are experiencing them directly what some of those might be, and then partnering, I think is really important.
Great.
Yeah, so there actually is a lot of grassroots effort already going on in Chicago in terms of trying to address this issue. As a medical center, the University of Chicago just opened a level 1 trauma center for the first time in decades. And through that, we actually have had a little bit more funding, and we've had definitely renewed interest in addressing the issue. We're also pretty fortunate in that Michelle Obama started the Urban Health Initiative a while back, and through that, we actually do have pretty incredible levels of community engagement. And so, there have been a lot of efforts and initiatives. And annually, our medical center actually surveys the community at large to understand what their #1 health priority is. And this year, it actually was violence. And so I think that there's a lot of desire. I do think funding still is a major issue. And that, I think, tends to be the big thing that holds us back. And so, I think that there is a lot of desire, a lot of will, a lot of interest, a lot of research, a lot of people trying to work on this. And we have seen some improvement since 2017. But I think the funding issue, it's hard to imagine infinite funding, because that's kind of the main problem that we've been dealing with for a long time.
Okay, thank you. For Hannah and Bo, I'm struck by a challenge. This is not the only area we face it, but Hannah, your work talks about heightened risk of a certain phenomenon. Bo, you talked about screening. We don't have certainty in this world. We have probabilities, and you have subpopulations or circumstances where the risk is higher than average. How do we, in a world of limited resources, not just for research but also for treatment and intervention, how do we think about bringing together the risk assessment with the intervention so that we're maximizing the value of the intervention? You don't want to intervene on a large number of people where the risk is actually relatively low, but you don't want to wait until your risk factors are so high that your probability is so high because you're going to miss a lot of people. How do we think about those issues? You can go ahead first.
Yeah, is this on? Yeah.
I think so.
I think about that question a lot. I mean, and I don't think there is, I at least don't have an answer. I think it depends on how high the risk is and then what the intervention is and what sort of harms the intervention may cause or not. And those, and I mean, I don't mean this as a cop-out answer, but I actually do think that it sort of, there are trade-offs and those issues have to be considered. As I sort of said in my talk, it has been at least one of our primary means of trying to deal with firearm violence that we restrict access to those who we think are high risk. But it's the way we do that is pretty crude. It isn't a risk assessment instrument. It's just these sort of categorical restrictions on felonies, et cetera. And so, within that framework, I think it's useful to think about what indicates risk. But you could imagine sort of more nuanced as well. So I don't have a single answer, but I think it's an important question to keep in mind.
Well, I totally agree with you that there aren't completely unlimited resources in the healthcare business to just screen everybody for everything. But I also know, I mean, I had a colonoscopy last week, not a pleasant experience, but why does someone my age get one? Because I'm in the risk factor. And so we do that in the healthcare business. We do expensive things on patients when we think they need them. Well, I personally believe in what I'm learning in and the reason we put together our workforce at KP is that we believe that physicians, especially of my day of training many years ago, we never talked about any of these issues that we're talking about today. And so we have to start at the beginning of at least educating physicians and providers of the importance of screening for certain things. So when you have a woman in your office, you need to screen for IPV. And if you learn that she is at risk for IPV, you also then need to screen for, do you have access to firearms in your home? And I think if we can educate our providers about what are the risk factors, we certainly won't be perfect, but we need to spend energy on that because otherwise we're never going to solve this public health issue. And so that's really the goal of the work I'm doing, is to try and get to that point where we can specifically use what we know are risk factors and then hopefully intervene effectively and make a change.
That's great. We got a little late start, so I'm going to run a little over, but I wonder if there are a few questions from folks here. You have access to some very knowledgeable people here, Judy.
Hi.
Let's get you a microphone so the folks on the...
Thank you very much. I've got two questions. One, for Hannah, essentially, you've affirmed what I think many of us who've had impact with violence says, that violence can actually make you physically ill. I guess, was the connection specifically with hypertension? How did you isolate that? Because, those of us in the African American community, it's like, the problem is you're not eating right. And others, really do say living where they're living with violence and trauma really has impacted their health. So you've kind of opened that door, and I'm just wondering how did you isolate it to connection with the hypertension and not some other factors? So that's one question. Okay. The other question to you, is it Robert? Is I'm wondering how long has it been the protocol through the Pediatric Association about asking the question as part of maybe family history about firearms? Is it too early to determine if just asking that question and engaging with patients as part of just regular protocol, if it has had any impact at all, or do we still need to get more data on that?
So on the hypervigilance and hypertension link, so essentially, yes,
okay.
that's okay. So essentially, we used fancy statistical models. And so essentially in those statistical models, you can adjust for a number of things. We ended up doing a host of models, and essentially that link still persists between high levels of hypervigilance and hypertension. It also helped that we sampled from a more homogeneous population rather than a heterogeneous population, and so you isolate some of the effects by making sure that people are more similar in terms of demographic characteristics and all of those things. But I don't know if that answers your question. Okay.
So thank you for your question. Pediatricians, and really we're under the guidance of the American Academy of Pediatrics, for many, many years we've been asking all kinds of health risk questions. They certainly have evolved recently with the more focus on ACEs and social determinants of health, and I'm excited that Nadine Burke-Harris is our new Surgeon General, and I'm also excited that there's now been money put towards gun research at UC Davis, my alma mater. But back to your question, I think even though we've been asking parents, I think pediatricians have been bashful about it. I had a patient tell me, bring me in an NRA sticker as a joke. He gave it to me, and I said, well, what's this about? And he said, well, you keep asking me about whether I have guns in my house. Of course I have guns in my house. And I think what he really taught me was, you don't just ask the question, and I think parents want to be asked questions like that because they want to know that we're concerned about the safety of their child, but they also are expecting us to do something with the information, and that's where it's getting challenging. And back to what the work I'm going to focus my attention on in the near future is to train our physicians on what are the resources that they can use to help when they get the information. And for pediatricians, hopefully it will be educating the parents on safe storage of a weapon. It's fine that you have a weapon in your home, but I just want to make sure you know the risks of having that weapon and how can you prevent anything from happening. No different than when we talk to parents about pool safety, which is very important in California. So it's a big effort and hasn't been something new, but I think what's new now is that we're going to hopefully try and make a difference, and I think that's going to take education.
We'll get the microphone to you, too.
Hello, my name is Mercy. I'm a pediatrician. I actually work with Dr. Riewerts, and I wanted to just tag on to that and say that one of the things we've done in the last 2 years is we actually created a patient handout about gun safety and how to safely store your firearms at home, and that it's the parent's responsibility to keep the children safe. And so when we ask that question in the Well Child Screener, what we ask our physicians to do is actually give that handout if the answer is yes to the parent, or even if there's a handgun in the grandparent's home, to share that handout so that they can take it home and be more educated at least about safely storing it. We're actually adding into our electronic system in the next couple months when they revamp it for 2020. We're adding in a little box that the physician can actually just click guns in the home counseling as a diagnosis code, and then click on another box to automatically load our handout to be printed out. So it's easier for all the physicians to even code and give that information.
Thank you for my plant in the audience there.
Here comes.
Hi, Ray Baxter from Blue Shield California Foundation. I have a question that's really posed by so many of the articles in the issue that I'd like to ask you about it, and that is that when we ask people about their experience with violence, both the effects and causes and the nature of the experience, they seem to tell us one set of things. And the public dialogue around violence seems so much at odds in so many ways with what we have been learning in the research. My question is, so there's this gap between the way we talk about this in public discourse and what the research seems to say. What's the biggest myth that you would like to bust, either with knowledge that you've already gained in the field or that research might shed some light on in a very different way?
That's a great question. I think you may have stumped him. Now's your chance.
I'll jump in first. There's a lot of myths in the world. I mean, one of the things pediatricians deal with a lot is we struggle with the fact that about 95% of Americans appropriately vaccinate their children, but if you read the front page news, you would think that there's a lot of anti-vax rhetoric out there, and there certainly is a lot of rhetoric out there that we are consistently trying to face and change that perception. My feeling in your question is we're focused so much on the right to own a firearm and the Second Amendment and don't get in the way of my personal choice of whether I own a firearm or not. And I think the current public health issue is really about, this isn't about whether or not you own a gun. It's really about being responsible, no different than if you own a car. We have a set of standards that everyone pretty much now adheres to for the most part on how you operate that automobile. And we have to convince the public to understand the potential danger of having a firearm in your presence if indeed there's something else going on in your family, which could be an abusive relationship. It could be that you have a teenager who's struggling and being bullied at school, and on and on and on, and just get beyond all of that. That's my feeling.
I would say one of the myths I think is out there is particularly about the youth that I work with is that, and the communities, that they're so disadvantaged, there's all this violence, and hope is gone, and I think there's a lot of hope there and a lot of assets that we can leverage. And so for the work that we're doing, when we held our community forum, more youth from the community showed up than any of our providers or, adult sectors, and they were ready to work. And so I think, and they have resources, they have, networks. And so I think there's a lot of opportunity that we're missing by being so focused on just the problem. Of course, we have to document and understand it, but there's also these assets and resources we can be leveraging. And it's complicated because, as you heard, youth recognize there's a lot of problems, so it's not to say that those aren't there, but I think the solutions can be a bit more strength-based, and that's something that you don't often hear in the discourse.
So I would say in the neighborhood violence literature, there is kind of this bias towards saying that neighborhood violence is a youth problem. But Tony Rosen wrote an excellent piece in this issue that violence very much affects older adults as well. And so that would definitely be a paper that I would pick up and read.
Okay, I'm going to answer your question, and then we're going to close out the session, because I was thinking, in some respects, I'm reflecting back on your opening. I think there's if you think about the history of stigmatization around mental illness, mental health, which of course still exists, in an environment of stigma, the most dramatic stories are the only ones that are told, the only ones that break through. And I think we're there with violence, that the common, one of the overview papers just describing the prevalence and presence of violence in so many different ways. When there's stigma about that, what you talk about is the very dramatic elements like mass shootings, but the dailiness of it is lost because people don't want to talk about that. That's my try at an answer for what it's worth. A great start, a great evidence-based start, but also practical, grounded in the real world. Really appreciate these voices. We will take, as I say, we're running a little behind, but I think we'll make it up. Let's take a 10-minute short break, but please join me in thanking our panelists this morning. So two of the studies that were presented, actually two of the authors this morning, their work was very much rooted in the community And we're so pleased to have representation here from Youth Alive, a community-based organization based in Oakland, founded in 1991. Ann Marks, Executive Director, is here with Briana Dunn, who works with the organization. And I am just going to turn it over to them to let them talk about what they're up to and what the implications are, how that all feeds in, so that we're not just here talking about research. And I'm happy to turn it first over to Ann. Take it away.
All right, thank you so much. It doesn't seem like it's on. How's that? Is that working now?
They'll get you. They'll get you.
You'll get me. Is yours working? Hello? Hello? Still nothing. Hello?
Take the one next to it. It was working a second.
This one here? Oh. This is great. All right, thank you. We'll see what happens with this. It'll be fun. Okay, so thank you so much for allowing us to come here. So I am just going to pop this guy out, put it in here. Right? Problem solving is a key component, right, to being a community-based organization. So I want you to see that in action and how that works out. Thank you so much for letting us be here. My name is Ann, and I am with an organization called Youth Alive. We are here from Oakland. Oakland is, wow. I'm just going to hold it. Oakland is like many other the communities that we've heard about today, right, like Kansas City or Chicago or Los Angeles, with the exception, of course, that it's better. But I think, a lot of things we're going to talk about, I want to be clear, it's a perspective rooted in our experience in Oakland, but I think there's a lot that can be shared across other communities. We're also going to talk a lot about what we're doing in terms of community practice, community engagement, and the work we're doing around violence in Oakland. But all of these things are awesome, but they're actually not unique. They're models that exist in other places, or in the places that don't exist can easily be adapted in other places. So I want to make that clear, that we are here representing Oakland, but also representing all the communities that are impacted by violence. I want to thank the California Wellness Foundation for having us be here, Blue Shield Foundation, also see our partners here from Hope and Heal and from Kaiser Permanente. So thank you so much for letting us be here. I especially want to thank Health Affairs for bringing me and Briana here to enjoy Taco Tuesday in Los Angeles last night. That was great. Appreciate it. Before I say a little more, I'll go ahead and let Briana introduce herself, but also say a couple things about her that she may not do when she introduces herself, which is to mention that she is, in addition to having gone through Youth Alive programs, she's a college student, and for several years was also a commissioner on the City of Oakland's Planning and Oversight Committee for the Fund for Children and Youth. So, if you want to say a few words, Briana?
Yes. Hi, everyone. Is this on? Yes.
Yeah.
Okay. Hi, everyone. My name is Briana Dunn, and thank you guys so much for giving me the opportunity to be here today. I really appreciate it. But yeah, I was born and raised in Oakland, California. I don't really have an idea of what it is that I really want to talk about today, so I guess I'll just go ahead and talk about how the Youth Alive program has helped me. Like I said before, I was born and raised in Oakland up until the age of 5. A lot of things happened in my life where my grandmother, she took me in, and she lived in San Leandro, which is not too far from Oakland, but it is more of a sheltered community. And she raised me in San Leandro for the next 10 years. She was heavily involved in church, and my uncle, who also lived with us, was also a school teacher as well. And so we just got a lot of one-on-one attention through my grandmother and my uncle. When I finally moved back to Oakland my freshman year of high school, I sort of had to readapt. Which I didn't think was going to be that hard, but it was pretty challenging. Growing up, for the past 10 years with my grandmother, I was, again, so sheltered, and I didn't really, talk to many people. I was just, used to just going to school and then coming straight home, and getting my homework done. But When I moved back to Oakland, I started going to Cacioppo High School, and at Cacioppo, it's a really like lively school, and just everybody is everyone they're just really open, and I was introduced to the Youth Alive program because I was a victim of violence. During my senior year in high school, I was caught in a crossfire at the bus stop on my way home from school. And that was a super huge culture shock for me because I never thought that I would be involved in something like that. I wasn't the target, but I was doing the same thing that I did every single day, which was wait at the bus stop, on my way home from school. And in that moment, I didn't know what to do. When I did end up in the hospital later on that day, I was met by a group called Youth Alive, and I had no idea that they would have such a huge impact on my life from that moment until this day. And so ways that they have helped me was they helped me through therapy. I didn't think that I needed therapy when I was going through everything that I was going through, but going through therapy actually helped me realize that I was suffering from anxiety and also PTSD as well, and I would have never known that. Other things that they also helped me with was making sure that I got reintroduced, back into school, and making sure that I didn't, fall behind. They helped me apply to college and made sure that, I had all of my classes picked out for this semester. And they gave me, so many different opportunities. For example, being able to become a youth commissioner for the Oakland Fund for Children and Youth. And so I just really appreciate the program for just never letting me go and always following up with me throughout the years, and just caring about me. And I feel like there aren't a lot of programs, or just a lot of programs out there in Oakland, period, that hold you by the hand and stay with you for like years to come. The only program that I've ever noticed that does that is the Youth Alive program. I also throughout high school with the Youth Alive program, I also did different workshops after school with them, where they taught us the different types of violence and how to prevent them. And what we did was we would go to different middle schools and elementary schools in the neighborhood and as peer educators, and we would just talk to the kids in the neighborhood on how to prevent violence, and just sort of like a workshop to more like relate to like the kids in the neighborhood from like a peer perspective. But again, thank you guys so much for the opportunity to be here and share my story, and let you guys know how I was a part of a violence prevention program. So thank you.
Yeah, thank you, Briana. Thank you, Briana. So Briana and I had never presented together before, and we said we were going to react to some of the things that we heard this morning and bounce off each other a bit. So there'll be more from Briana. And I think, so you kind of laid out some of the pieces of what Youth Alive does. And again, we are one community organization. There are many community organizations. So I really want to put this in the lens of these are the kinds of things that community organizations can do to address violence as a health issue. At Youth Alive, we have a number of programs. We think of them as being in three categories. We think of it as being prevention programs, intervention programs, and healing programs. When we think about prevention, right, this is really, I guess, what you would call addressing violence as a public health issue, right? Our prevention programs are like the program that Briana was part of, where she became a peer educator and was able to go into schools and talk to young people about what to do if you're being recruited into a gang, what to say to someone who's carrying a weapon, why it's dangerous to have a gun, how to identify domestic violence, that type of thing. That's prevention. We also do social norms, organizing. We also do policy work, because that's all part of sort of this public health approach to addressing these root causes and social conditions. So that's a key component of what we do as an organization. But we also have our intervention and healing programs, and I would say that's really addressing violence not specifically as a public health issue, but as a health issue. And so to talk about that a little bit, what that means is intervention programs. One of our programs, Caught in the Crossfire, is a program that Briana was also involved in, as she described after the incident that happened at the bus stop and where she ended up in the hospital. And so that's a program that we intervene in a moment of crisis. And so this takes from the health field, right, where we talk about intervening in the golden moment, right, when a health crisis occurs, right? So if it's a heart attack, right, there's a moment there where you don't just patch someone up and be like, bye, but you talk to them, right, about how to, what their aftercare is, about health and nutrition, about who's there to take care of them as they're recovering, and what their future health plan is, right? That's the golden moment. So the golden moment, we find, is to intervene in the immediate aftermath of violence. Another place that we intervene is when someone is coming home from incarceration. That is a moment where someone's life can completely change, can go in a number of directions. And so we find that by intervening then at that moment, we can really help someone on a path to better outcomes and to safer outcomes. And another intervention program we have is something that we call violence interruption. I think a lot of people are familiar with the Cure Violence model. I know we got our folks from Chicago here. But it's basically street-based conflict mediation. It's identifying when there's an issue where there may be safety concerns and addressing those in the moment, right? And how to mediate and restore what's going on there so that it doesn't escalate further to violence, further to retaliation. And so when we think about our intervention programs, we're really thinking about sort of these proximate causes of violence, right? The risk of retaliation, the risk of mistaken identification and retaliating against someone that's not even involved, in bringing this to a whole other level. We're talking about the dangerous things that people might do in the aftermath of getting hurt, like deciding to carry a weapon or deciding to join a gang to feel safe. But we're also talking about the less proximate health issues, right? Which is some of the psychological and social impact of what happens, right? What the social norms are around coming home and who's going to care for you, right? We heard a lot today about loneliness, right? And social isolation that you might feel when you don't go outside anymore. Or hypervigilance, right? Where you are on edge all the time, can't focus anymore in school. You have trouble interacting with people without being that hair trigger response, right? I mean, Briana shared, I think, very honestly about her own, right, psychological reaction to these things. And these can really impede, right, your ability to live a healthy life. And so there's those other causes. And that kind of leads us to what I would say is our healing work. So we have healing programs. One is named in memory of the founder's son, the Gaddafi Washington Project. It's a program that responds after homicides. And it helps the family and friends around that to respond, to recover. I think, we heard today from the other Briana, right, around what it's like being exposed to violence in the community and what impact it has on you. And one of the things I took away from that was how mental health access kept coming up, right? So when we talk about healing from violence, that is very, very clearly a health issue, right? Mostly a mental health issue. And I don't mean just a clinical mental health issue, right? But a health issue that involves or requires all kinds of healers. And so that's what we have at Youth Alive, for example. We have clinical mental health, but we also have these other healers, these other trained healers who do their work. Because I think Ray opened the day by saying, exposure to violence is its own root cause of violence. So how do we respond to that? And I was struck by Judy Belk, and I'd heard her mention this before, right? Like, when I look at her and I hear her story, I think, you're a healer, right? And like many healers, you are someone whose own history of recovering from violence in your family, in your life, has given you a window into how to help others. And so that's why you're a healer now. And what we find at Youth Alive is that most of our healers are people that are in their own process of healing, right? So Briana was tremendous going to classrooms and talking to young people about violence. because of her own experience growing up in and around Oakland and being able to relate to them, right? They look at her and they're like, well, she's a couple years older. She's cool, I mean, obviously a very cool person, right? And they get it, right? And her own experience could help that. You know, the person who came into the hospital room and first talked to her was someone who was a graduate from her same high school. You know, so there's something that's really meaningful about people that have some kind of shared experience, right? So they say, you know, hurt people. And we believe healed people heal people. And so this kind of gets to how do we think about violence as a health issue and what does that mean in terms of implications, right? So, well, let me just pause there for a second in case you have any response before I keep blah, blah, blahing, Briana.
No, you're good. Go ahead.
So, when we talk about the kinds of programs we have and the kinds of healers we have, I want to say just a couple things about looking at particularly what that means. It means that law enforcement has a role, criminal justice system has a role, but it can't be the only piece, right? That's what we mean by health approaches, and that's why community organizations are so on board with health approaches, right? Because, you know, if all you have is a hammer, everything's a nail, right? And we're not nails, we're people. So we need these other approaches. And so how do we integrate them? I think one of the things that's interesting, and I know that Bo, was that your name? Dr. Riewerts talked about was the role of the health system. And the health system itself, so it's not just that it's a health issue and community approaches that are non-criminal justice approaches are important, it's also that the health system itself has an incredible role, right? If we're looking at 2.3 million emergency department visits, I think I saw, $8.7 billion, right? This is now a system that is intersecting with this issue that needs to actually engage on this issue, right? This has to be a place where these things happen. So we mentioned hospital-based violence intervention. Youth Alive is very proud to have had the very first hospital-based violence intervention program in the country, which is now a national model, thanks in large part to some of the people in this room who've helped promote it in other communities, and we'd be happy to tell you more about how to get a program started in your community. If I could plug a website, the HAVI, the Health Alliance for Violence Intervention.org, has lots of information about how to do that in your own community. But in terms of the role of the health system, hospitals see so many people affected by violence, right? And we have that golden moment there. So how do we take this resource-rich environment, right, that sees these patients, that sees these victims, and make sure that they are turned toward the care that they need? A scary statistic that I sometimes mention is that it turns out 44% nationally, 44% of the people who end up in the hospital with a gunshot will come back again with another one within 5 years. So even if we don't think about sort of the moral consequences, right? The science says that is some bad care. So how do we look at that? How do we intervene in that? And I will say one thing about this, it's partly that violence is not just the result of a lot of conditions, it's actually a cause of a lot of these conditions. And so we need to find ways to intervene. That in the criminal justice system, the distinction between victim and perpetrator is very central to all that they do, but it's in fact not particularly science-based and not particularly useful if you're actually trying to reduce violence. And so when we look at policies that are actually effective in reducing violence, and let me just say this, 44% of people nationally will come back. We found last year at Youth Alive, less than 1% of the victims that we work with came back with another injury. So these programs work. How do we actually use the health system as a basis to invest in these things, invest in community programs? So one way is to talk about the people that do the work. There is now a category in the healthcare taxonomy called violence prevention professionals, right? These are people that save the healthcare system money by working with people who are at risk for violence and helping them to recover, to heal, and to avoid future violence. This is an area that we need to be investing in, not just creating a category, but actually paying them. This is something that we actually tried to do in the state of California this year with a bill called AB 166, which made it all the way to the governor's office, but inexplicably he vetoed, because apparently if you have to spend a few $100,000 to solve an $8.7 billion problem, you need to go through a more clear process. So that was a disappointment, but I think we have a way to get around that. A second thing we can talk about is trauma centers, right? Trauma centers are required to have injury prevention prevention as part of their certification level 1 trauma centers. And yet, there's no requirement that trauma centers that see a significant number of violent injuries have to have violent injury prevention as part of what they do, right? So you have hospitals that are seeing significant numbers of gunshot wounds, stab wounds, physical assaults, and their injury prevention program is, again, very important, these things, but solely things like fall prevention and child seats, right? Child seats in their cars. And these are all, again, important things, but cannot really address this issue if the resource-rich environment where people are being treated is not actually addressing the injuries that they're seeing. And then I think just the last thing I want to mention around policy, and I know we're kind of going there in the latter part of this session, is around how do we invest in some of these things at the level they're invest in programs and the levels that they should be, and reap the benefits of it. So people talk a lot about, it's fantastic to invest in schools because then these people that go to school, they grow up and they make money and they pay taxes. But, the school district doesn't see that money, right? So like, well, maybe it saves money, right? This is our thing as prevention professionals. We're like, well, nobody sees that money. But for a hospital, they do see the cost of treating someone for violence, right? They do see the directly, right, the expenses of caring for injuries, particularly injuries that have long rehabilitation required. So there's a way to think about not just as a human issue, how do we address violence and how do we invest in community strategies that work, but how do we actually make sure that the systems that are investing in them are actually going to be the same ones that are seeing this benefit. So a study was done, and it said if a hospital invests in violence intervention and it prevents one re-injury a year, it is cost neutral. If it prevents 2, it actually saves the hospital money. Right? There's not a lot of things we can say that about, right, that are actually saving money for the same entity that they're investing in. And so I think one of the questions that community organizations have is like, well, we know what we do works. We know that some of the places that invest in these methods can save money by investing in them. And so the question is, well, why aren't they? And so I think it's a lot about paradigm, right? How do we think about violence? So my hat goes off to health affairs for really thinking about, like, we have to think of violence as a health issue, or else we're going to keep looking at the wrong solutions, right? We're going to keep using a hammer and treating everything like a nail, and that's not what it is. So we have to change the paradigm, and I want to go back to some of the papers we heard today. We have to think about the influence of race and racism on this issue, right? And who is considered a worthy victim, right? Who is considered a patient whose care is worth investing in. And so that is a battle that we face. I'm really glad to be in a room with people who are on board with that. I want to pause for a second because I did a lot more blah, blah, blah. Any more thoughts, Briana?
I'm good.
All right. I think that's it from us. Thank you so much for having us here.
Thank you so much for being a part of this. And again, it's just so important that we have these conversations at both the evidence abstract level and the human level. And what's great is to bring the two together, and the level of thought and evidence building and evidence use in work in the community is something we're so happy to be able to contribute to. So we're going to turn to our final panel. If we could have our speakers join us. I see Sandra coming up. Where's Rahn? I saw there he is. So that was a perfect bridge to the policy discussion, which was part of the papers, but now I want us to just stay there for the balance of the morning. You're going to hear from Sandra Henriquez, Chief Executive Officer of CalCASA, the California Coalition Against Sexual Assault. Genevieve Flores-Haro, Associate Director of Mixteco Indigena, a community organizing project which serves Ventura County's indigenous immigrant community. Ann Tremblay, Director of the Office of Gang Reduction and Youth Development for Los Angeles Mayor Eric Garcetti. Ron Kennedy Bailey, Associate Dean of Clinical Education at the Charles Drew University of Medicine and Science. And so what I've asked I've asked these folks to just take a few minutes at the outset to describe. They work in very different environments, but all so important for understanding the topic that we have today. So ask them to sort of begin with a little bit of where they are and what the policy issues that they're facing, and then we're going to do our best to weave them together and draw some lessons from them and have you all engaged in the conversation. Let me turn first to Sandra.
Great. Good morning, everyone. Can you hear me? Yes. Hi. Yes, I'm Sandra Henriquez, the CEO at the California Coalition Against Sexual Assault, and we've been around since 1980 and do both statewide and national work to end gender-based violence, both sexual and domestic violence. And just in terms of a little bit about the way we're organized, we represent a large part of the state's safety net, which addresses and responds to both sexual and domestic violence. We have a counterpart which is specifically focused on domestic violence. We had originally been specifically focused on sexual violence, but because of a lot of our national work, we cross over, and a lot of our the programs that we work with and on behalf of, obviously the issues don't get separated out neatly that way. There's a lot of crossover and intersection between the issues. So that's just a little bit about the way that we're organized. I did want to start off by doing a shout out to the two foundations that are here, both the California Wellness Foundation, who I had the opportunity to work with in the early 90s to early 2000s when they were very forward thinking and invested in something called the Violence Prevention Initiative. So really looking at the connection between alcohol, guns, and violence, and did a lot around policy and community organizing. So I really appreciate that because that was at a time when nobody was looking at prevention. And then I also really want to acknowledge Blue Shield, who earlier this year who's had a longstanding commitment to addressing domestic violence, and who earlier this year really came out and said they were going to focus on the prevention aspect. And so I really appreciate that. It's something that I have found, it's been very frustrating because prevention is really hard to get people to focus on and invest in. I wanted to just give you a little bit of background about the funding history in California around these issues. So the California General Fund has for some years made a commitment of about $20 million to address the issue of domestic violence, and that has really gone to fund primarily shelter-based programming. They have made, in that same amount of time, a $45,000 a year to address the issue of sexual violence. Before last year, we had never been able to get them to increase that. And so back at about 2011, we made an effort to get the California legislature to increase from that $45,000, which works out to less than what you pay for a cup of coffee to serve the number of victims in the state. And what happened for 2 years in a row when we tried to get them to make an investment to address the issue of sexual violence was that they kept saying, we care about the issue, but let's find another way, we don't have the money. So at that point I said, okay, this becomes a money issue, so let's make a case for why they need to invest in prevention because it's going to save them money. So in 2012, we commissioned one of the leading researchers in the nation named Ted Miller, who works on cost reports. And he worked on a report and what the cost came out to in California for a snapshot in 2012 was $9 billion is what sexual violence cost the state of California per year. And those are tangible costs, looking at things like health care, mental health care, property damage, incarceration, et cetera. When we look at intangible costs, so loss of work, productivity, et cetera, then we come to $140 billion. So we finally were able to release that report in 2018, and we used that last year to go to the legislature. We partnered with the DV Coalition, and we went together and said, give us $50 million to prevent sexual and domestic violence in our state, because just in sexual violence alone, it cost us $140 billion a year. They could not understand or get behind that. They could not understand the idea of prevention, and every time we'd talk about it, they continued to talk about services. And believe me, I believe in services as well. However, we got to go upstream. We've got to prevent it. We've got to do that. And so that's been an ongoing, I'm rushing because I see the timer. And so that's been ongoing work to try and get them to really understand. We were successful last year in getting our governor to approve $5 million for each sexual and $5 million for domestic violence prevention. Well, they didn't really make it just for prevention, but anyway, so that was some success. This year, unfortunately, it went down to $5 million for both, so we were a little bit bummed about that. And I know we're going to have questions, but I did want to just say this. We really believe that criminalization is not going to end sexual or domestic violence. We really have to prevent it. We have to work with people at a young age. And I'll leave the rest for questions, period.
Thank you. Great. Just checking. Okay. Good morning. Can everyone hear me? I'm going to have to eat the microphone. Hello. So good morning, everyone. My name is Genevieve Flores-Haro. I'm the Associate Director for the Mixteco Indígena Community Organizing Project, or MyCOP for short. Before I go in to my comments, I would like to first ground us and acknowledge that here in Los Angeles, we're in Tongva, Band of Indian Territory land. Whenever I speak, I like to remind ourselves that wherever you stand in the United States, you're on Indigenous people's land. And so just wanted to offer that to the room. I would also like to thank Health Affairs for the invitation, as well as Blue Shield California for recommending us. As a two-time Trojan, it's always nice to come home. So fight on. And also really quickly, wanting to shout out Blue Shield California Foundation and the California Wellness Foundation as funders of MyCOP's work. This is a very interesting opportunity for me as it intersects the work that I supervise at the organization in terms of health policy and domestic violence. And so in addition to being the Associate Director of MyCOP, I also co-chair the Culturally Responsive Domestic Violence Network. It's a California statewide coalition of 17 organizations that are working at the intersection of culture and domestic violence. And that network is also supported by Blue Shield, so thank you. So really quickly about my organization, MyCOP, we support, organize, and empower Indigenous migrants living in Ventura and Santa Barbara counties. When I say Indigenous migrants, I mean folks that are Indigenous to Southern Mexico. Many of our community members come to the United States to work in agriculture. Ventura County is home to a $2 billion agriculture industry, luxury crops like strawberries, avocados, citrus. And so many of our community members come and work and pick the fruit that we eat here throughout California and the United States. A lot of our work deals with language access, and a lot of it deals with that cultural barriers that our community members face. Oftentimes, when our community members seek services, there's either a language barrier or the organization or agency feels that they have a Spanish speaker that'll cover the services that the community member needs. And again, that's across whatever service they're trying to access. Again, we have 19 different programs because we're the only organization serving that particular community. We have a youth group, case management, community organizing, a radio station, as well as, again, the health access, mental health, domestic violence programming that I mentioned earlier. And a lot of the work came about as a response to community needs. type of violence that our community members encounter, as you can imagine, as immigrants to this country, as someone who doesn't speak the dominant or the second dominant language, Spanish, we have traumatic immigration experiences, racism, not just among the broader community, but among Mexicanos. Just like here in the United States, there was a lot of anti-native, anti-indigenous sentiments. That's the same in Mexico. We are often at the bottom of the totem pole, looked at as dumb, given the worst type of work when we're working in the fields. So that can affect, one's psyche, one's mental health. Again, there's domestic violence, unfortunately, and that has a comorbidity with alcohol abuse. So a lot of what we work on are culturally grounded responses. That's the crux of the work that we do, because when our community members go to seek services, the talk therapy is not going to work for them. Going and giving their most intimate secrets to a stranger doesn't work for them. So we've had to develop tools that are more culturally appropriate for our community members. And when we go and try and pitch for funding, a lot of what we get a little pushback from is, well, what's your evidence-based? And so recently, in the last couple of years, we have taken it upon ourselves to be our own evidence-based, to develop our own evidence-based practices. So we are currently running 2 concurrent studies. And it's interesting because one of them is the California Reducing Disparities Project, which is funded under the Office of Health Equity, which is funded under the California Department of Public Health. So again, you have that nice little connection with public health, mental health, and domestic violence. And so rushing through this, again, we're creating our own evidence-based practices, but you can't do that and not have the policy change behind that as well. As a lot of folks in the room have said, whether you're on the research side, whether you're on our community-based organization side, a lot of it has to do with funding and where that funding goes, how that funding's allocated. So we were actually part of that first funding ask, and our little niche under that funding ask for the state of California was we need culturally responsive programming, because as an organization like ourselves, we're not a shelter, so we were excluded from domestic violence funding from the state. Looking at the different intersections of our community, it's not just, having more culturally competent mental health services, it's also having a safe state, like with AB 54 declaring California a safe state for immigrants, health for all, access for our community members. And so I think the big gap that we see at the moment is men and boys. And I feel like a lot of philanthropy is pivoting towards that, which is great for us to see. We're just hoping that the state of California will follow as well. So thank you.
Good morning. I'm Ann Tremblay. I'm the director of Mayor Garcetti's Office of Gang Reduction and Youth Development. I'm very happy to be here with you today. And like Ann said earlier, I'm here representing certainly the mayor's office, our team in the mayor's office, the GRID office, as we call it, GRYD, the GRID office, so you'll hear me say that a few times, as well as our 25 community-based contractors that we fund to do the direct work of gang prevention, intervention, and violence interruption throughout the city of LA. We're a bit unusual in government, the GRID office, because we really are both a policy and a practice shop. We're part of the Mayor's Office of Public Safety, but we're also like a small city department. So typically, certainly in our city, in a mayor's office, it's a policy team, small groups working on policy, and then being the liaison and nexus with different city departments to help guide the mayor's policy to be implemented within those city departments. For us, we are that small city department, as well as part of the mayor's policy shop, so a very close connection and nexus. We were very fortunate. The Mayor's GRID office was actually started under the prior mayoral administration, and fortunately that was something that was continued under Mayor Garcetti's administration. There was a lot of fear and concern that this work that had been invested in, because it was in the mayor's office, would not continue into a new administration for a lot of the political reasons that you can imagine that sometimes happens with initiatives that a mayor takes on. in any city in the U.S. So what's happened in our city, fortunately, is this great combination of what the community asked for and demanded, of having the issue of gang violence prevention and intervention, of taking a non-law enforcement and non-suppression oriented approach to gang violence in our city, is something that's now ingrained in our city. In 2007, certainly this work was going on through other city departments in a very piecemeal fashion, but now we're one shop overseeing it all. What started in about 7 or 8 communities throughout the city is now in 23 what we call grid zones. All elements of the work are in all of those grid zones, and we're very fortunate to have a mayor and a city council that have valued this work, and we now have over a $30 million annual budget from the city's general fund. We also have some state and federal grants. So big picture, what we really try to do is go with a place-based approach, because it's in those neighborhoods that we have the community-based organizations and their staff members that know and understand the communities in which they work. That is particularly important when it comes to the violence interruption approach. Again, Anne talked about that a little bit, of having folks with lived experience, folks that know and understand how to mediate conflict and can have influence on their communities. They can do rumor control. They can help prevent retaliatory violence. And we have a whole protocol that happens in the city in response to all gang shootings and homicides that includes those workers and also includes our team in the mayor's office. And our team in the mayor's office acts as that bridge and buffer between law enforcement and the community-based providers. We've invested very deeply in prevention, and when I say prevention, that's direct case management services, but that's secondary prevention. We have lots of programs throughout the city that support youth in primary prevention ways. We're focusing on youth that have the highest, show evidence of the highest risk of gang joining. We are very fortunate, too, that we've invested in a really strong data research and evaluation component of this work, and I'd say to any government folks out there, you got to invest in that too, because it really strengthens the work and allows you to keep innovating, and that partnership is led by a team at Cal State LA. So I guess I'd just close by saying we really have focused on taking a comprehensive approach, but approach that combines what the community needs and the community's assets, using the community's strengths more broadly, as well as those individual youth and families that come in for services, building on those strengths to provide the best possible service to them. And we've had great success with that. Thank you.
Well, hi, my name is Ron Bailey. I'm very new here, been in town and in California life for about 3 months. I joined as the Assistant Dean of Education at UCLA Drew, and I am a psychiatrist by training. I'm actually the new medical director, chief medical officer of Kedron Psychiatric Hospital. So we're going to touch these issues of violence, I think, vertically, I think, and horizontally. Similar to one of the other panelists, I would also say that although I didn't go to USC, I'm a very proud parent of a USC Trojan. My daughter actually went to undergrad here and finished in 13, and now she's in the USC residency program in orthopedic surgery. So very happy for my first time to be invited here to speak. Really like USC in many ways. My area to come into the issue of violence, I think, for this panel, a couple of concerns. First, as a psychiatrist, I think those issues we're going to address here shortly. Second, I think the attempt to address issues regarding policy was something in my organization, the National Medical Association, has really worked on for some time. I served about 6 years ago as the national president and made issues of gun violence really my primary theme. And we've been very fortunate now for about 6 years in a row. That's an issue that I think our president, including our current president, who's here in Los Angeles, has made really a key theme, and it's really been the gift that keeps on giving, because it's just so much of a concern, I think, across all communities. But one that we think physicians should have a very unique role to play. Some things you actually heard about earlier today, how we actually asked the question, how to fight for that. There was a case in Florida about a year or so ago where the legislature actually passed, but eventually retracted a law to prohibit physicians or psychiatrists have been asking about gun access and gun availability in the home, an area, I think, of scope of practice that we should actually really work substantially, I think, to protect. But the other issue, I think, is that we have a research orientation currently now. I serve as the NMA's chairman of the board of our Cobb Research Institute, and our theme is gun violence, with a focus on interpersonal violence or domestic violence. I was very happy to hear today many discussions about that as well. So the 4 or 5 points that I addressed to discuss regarding how I think policy issues are very key are as follows. First, we have a history of trying to address the issue of gun violence and overall violence through policy, really going back to 1968 with the Gun Control Act signed by President Johnson to address, I think, the tragic killings of Martin Luther King and Senator Kennedy. So we do have a history that historically, I think, try to acknowledge that there were too many guns, they were too powerful, and we had to use policy to try to address this issue of the scourge of violence throughout our community. So much of the propaganda discussion, I think some of my colleagues have mentioned on this panel and others today, probably missed the point that although we probably have not done this well, or as well as we probably could do it, we have tried, I think, using policy measures to address, I think, what has unfortunately become increasingly an out-of-control theme of concern, I think, in our country. Next, when we do try to address this theme, as I mentioned, we've probably not done it correctly. And no group should speak, I think, more loudly and more active voice than psychiatrists, because all too often the individuals who are disproportionately pointed towards as the culprit, incorrectly I would argue, are the mentally ill. Those with SPMI, serious persistent mental illness, those who have diagnoses of schizophrenia, schizoaffective disorder, bipolar disorder. All 50 states in the U.S. currently have law on the books to prohibit and preclude and limit access to purchasing and obtaining weapons by the mentally ill, although very few, if any, have similar laws that would actually limit access to guns by the individuals who the data would show are most likely to hurt themselves via suicide or others via homicide with guns. And those 3 groups are those who have SUD, substance use disorders, mainly alcohol. We heard about that earlier today. Those who have been victims of violent crime with guns, and those who have been perpetrators of violent crime with guns. We have some laws in those areas. So the disconnect between understanding and representing policy based on the science, based on the propaganda, is a huge problem, one that I think physicians, scientists should start to speak very actively toward. Third, I think this group is very aware of many of the other huge concerns, and one sort is the Dickey Amendment. We won't go through the details, hope we discuss it during the question and answer, but my challenge for physicians and physician scientists is that we can have a Dickey Amendment effort that, although it doesn't make it illegal to do gun research, is created really a chilling impact in a downward direction toward limiting such research. That could happen in any other area of medicine. What if someone decided that they didn't want you to know that eating a high-fat diet could be harmful for you, or things along that line? So the challenge, I think, to the scientists is extreme, and one I think we cannot at all ignore. My last 2 points were there was the Lautenberg Amendment that addresses issues regarding risk to intimate partner violence concerns. I've been shocked as I've been involved in this with a book about this a couple years ago to find out that women in a home where there's a gun are at double the risk of being violently harmed, not with the gun, just in general, physical. Somebody's more likely to punch you if there's a gun in a home. So it's a variety, we think, of psychological concerns that occur when there's a gun in a home. They may not be directly tied to the gun, but it certainly increases, I think, the representative construct of violence in that setting. And my final point really is, I think, it's regarding funding, that we finally are beginning to have small efforts to fund prevention in this area for gun research, I think, is a move in the right direction. Thank you very much for having me. Look forward to maybe the question and answer or some of these ideas.
This was terrific. I'm going to, as I usually do, I have a few questions myself, but I hope folks here will join in after. I was really struck by the number of references to prevention, and particularly both Genevieve and Ann talked about research inside your enterprise, which I think is just such, of course, we're an empirical journal, so we love hearing stuff like this. But I am curious, and I was thinking back to Ray's question about assumptions or myths out there, this question of the strength of the evidence base for prevention, how well understood it is, what the next steps are in advancing that base. So I guess my general question to all of you is, as you do your work, do you feel like you have a good base of evidence to build from? What's the next step in building evidence base, particularly around prevention? What would you like to know whether or not it works? Maybe that's
I'll try. So I supervise the research. I am not the researcher, so, but I'll take a stab at it. I think for us, the biggest question, because we're in the midst of both of these two research projects. One is a 5-year research project, so we're in year 3, and the other one is a 4-year research project. We just started, again, year 3. And so I think for us, in terms of does our community define practice work, is it evidence-based? I think for better or for worse, we're going to need more time outside of the 4-year and the 5 years that we have to study whether or not it works. So we're right now in the process of looking at what sustainability looks like for those projects. I think one of the bigger things for these projects have been just the simple pre or post, and I say simple pre or post, but it's really like a 70 question pre, 70 question post that we are given from the state of California, and that's hard to give a community member when you're trying to get their buy-in, when you're trying to have them enter your service, and you hit them with the 70 question piece. That's not necessarily culturally responsive. And especially if they're asking like SOGI questions, a lot of our community members are kind of just like, oh, but I was born a girl. Like, it gets really complicated. So I think for us, just having more time and just creating that awareness with the community members of why we're doing the work and why it's important.
That's good. Other thoughts on this?
Well, I guess I would just say, I'm certainly on the primary, community-based prevention front. I think around the issues of gang and violence. That's probably tough, and I haven't seen too much around that is particularly helpful about the community. Certainly the community level. Again, we on our prevention side are focusing on the youth, 10 to 15-year-olds that are at highest risk, and we're very fortunate. I'm a Cal Bear, but I'll give a shout out to SC among many of our research partners, again, headed at Cal State LA, but we have researchers from USC and UCLA that have been deeply involved in the development of this work. But 2 of the tools that we use, one on the prevention side, we use an eligibility tool that was created by researchers here at USC, using sort of the literature around risk factors for gang joining to develop a assessment tool specifically for our context here in LA based on what we knew with feedback from the providers on the ground. It's been a struggle, right, to make it culturally relevant, to get the trust of people to answer those questions. But our providers have really done a great job over time of connecting that to their practice. So on the prevention side, that's an eligibility tool, but it's also used in 6-month cycles to retest, to look at whether the risk factors have decreased and protective factors have increased. And we have a similar tool on the intervention side that looks at how embedded those youth and young adults are in the gang versus the community or family. And those have been very helpful us to our big focus on investing in the research and partnering with researchers. We pick those folks that we partner with very carefully because we can't traumatize these community members and folks more and more by having them be research guinea pigs for anybody, right? We're really trying to help make our practitioners have the information they need to make the practice better, to improve our models, to innovate, to be responsive, to do that in an evidence-informed way. We don't have an evidence-based, we don't do control groups for our prevention and intervention services, so we won't have those. But we do everything we can to make sure we're looking at what's out there in best practices, using an evidence-informed base to provide these services and to increase the tools that the on-the-ground practitioners, the case managers, the intervention workers have. So it's evidence to inform and inspire their practice, not research and data for research and data's sake or for publication's sake for our partners.
That's great.
Yeah, I just said briefly, much of the best data in psychiatry on prevention is in the area of suicide, much more so than homicide. And the suicide is very clear that when there's less access to lethal weapons, guns and knives, there's less actual suicide, although there may be more attempts and other, we're using more non-lethal measures. So clearly, I also look at what might be more helpful for us going forward is really to do analysis theoretically of location, because some areas try to limit access with gun reform. Also, access, I think, within homes or families, because some settings, based on safety maneuvers, there may be a gun there, but it may not actually be accessible by somebody else. The big issue for us, of course, is to push this consideration regarding biotechnology, where guns would be forced to be only programmed to be used by the person who actually purchased them. The absence of such data, such technology really hurts us tremendously. Very often persons can harm themselves with a gun purchased by somebody else. So it's a lot of work, I think, for us to do to get a better handle on how we can prevent violence.
That's great. While you have the mic, Dr. Bailey, you made a comment that reminded me of something that Ann Marks said earlier, that the distinction between perpetrator and victim is very important in the criminal justice system, but is not science-based. All of you are working in environments where there's some fluidity around perpetrator and victim, and I just wonder, that really stood out to me as a comment, but we didn't have time to follow up with it earlier. I wonder if any of you could comment on that. And
yeah, I mean, I'd like to, can you hear me? Yeah. Oh. This is an area that we're really looking at because we know that, there is some research, but also anecdotally, just from the work that's happening in California, that a lot of folks who cause harm have also been victimized. It doesn't always go the other way, but, a lot of folks who cause harm have experienced either childhood sexual abuse or lived in homes with domestic violence and or witnessed. And so, we really are looking at how do we kind of not throw those folks away, but really look at prevention comprehensively. So we obviously believe in primary prevention, right? So preventing it before it ever happens, but we also believe that we need to work with those who've already caused harm because they will be coming back into communities and into families, and they belong to communities and families, and oftentimes it's their very loved ones who will then kind of take them back in. So we feel that there's a really important and pivotal time there for prevention is to prevent the subsequent perpetration into, I know in terms of working with people who cause sexual harm, there is research to show that once there's an intervention and treatment, that there will not be reoffense, right, for a very high number of those who are actually convicted of sexual abuse. So I do think it's an area that's not just like we can't have it be black and white because there is a lot of crossover. And if we want to, that's why I made that comment earlier about we don't think that criminalization is going to end this, right? We have to treat, we have to work, and we have to do prevention comprehensively. So before it ever happens and once it's happened, and a lot of education with families and communities about what they can also do to educate themselves about the reality of these types of violence and how they can be a part of, not to place the responsibility solely on them, but that they can be a part of communicating with each other around what's happening and not keeping these things secret, because I think that's a big part of it. People don't want to talk about it. It's very, people feel very ashamed, but not talking about it, I think, increases the risk of something happening again.
One more thing I'd like to offer, in terms of it being a gray area, I think for the clients that we serve, there's also that, again, the immigration piece tied into it, as well as the economic piece tied into it. So like I mentioned, a lot of our families are farm workers, and you figure average wage of a farm worker annually is $15,000 to $20,000 a year. And when the average two-bedroom apartment in Ventura County is $1,900, $2,000, oftentimes our survivors can't afford to leave their husband, much less afford to call the police when, the husband probably is more bilingual Spanish in the indigenous language and the mom is more monolingual in her indigenous language, and the husband usually interprets for her. Oxnard PD maybe having a hard time, well, not now, but in the past having a hard time with interpretation. There's all these factors that go into whether or not the woman's going to, turn or say something. And then I think in terms, just like Sandra was saying, a lot of our men, have that and it's not an excuse necessarily, but, growing up with machismo, growing up with you must be the breadwinner, again, migrating to a completely new country, not speaking the dominant language. There's a lot of intersecting factors that we need to take a look at while we're making a plan to holistically treat the family and not just the survivor.
Yeah, I just simply add, clearly in psychiatry, this duality is pretty consistent. Our patients very often are viewed as being high perpetrators of violent crime, but the data makes it very clear that although by a small amount they are, maybe about 3 to 5%, but by a much larger number, about 40%, psychiatric patients, especially those with SPMI, are much more likely to be victims, I think, of violent crime. So I think that you make a good point. It has, I think, created, I think, a dissymmetry between understanding the relative risk. That's why so many of the laws, I think, very often, unfortunately, kind of go against or increasingly are draconian against patients who can really identify it as having chronic mental illness. The other big issue, obviously, is I think when you look at the data regarding violence toward individuals, very often it's interpersonal. So persons who actually hurt an individual who have mental illness hurt somebody who they know. They very often hurt their mother or somebody who's close to them. So regular society should not at all be afraid of mentally involved patients. They're unlikely to hurt them. But individuals who hurt them, when our patients are hurt, they're about people who they don't know. Persons who I think have a unfortunate propaganda-based prejudice against persons who have mental illness and are much more likely to have a very short temperament with them. So the risks, I think, are extremely well known, but we have not really been able to change that, I think, over time.
I have more questions, but I feel like I'm dominating, so I want to see who else says. I'll bring Judy in, please.
Thank you. Two questions. One that you're just touching on, and that's the impact on the immigrant community. And I'm curious, I think this is true, but at least it's been said, and I'd like to hear your thoughts, everyone, in fact, that with the current anti-immigrant policies and even violence against immigrants, that we know that there's been an impact on the immigrant community reaching out, getting health services that they need. And I'm just wondering, in the areas of domestic violence, sexual assaults, are you also in your communities seeing a reluctance on members of the immigrant community, especially women, reaching out to get support for law enforcement, for counseling, or to just stay safe?
Yeah, I would say yes. I think a lot of our work the last couple of years have been to intentionally work with, for example, Oxnard Police Department, where we're located, to do cultural competency for those officers, to put in interpretation contracts, to bring officers to our monthly meetings so that when our community comes to our monthly meetings, they trust us, they see the officer, they know that they can trust the officer too, they can trust the uniform. But all that goes out the window. Last year, for example, in South Oxnard, which has a high population of our community, they were doing a quote-unquote drug raid, but it was ICE, it was immigration, it was the National Guard, it was the sheriff from the county and Oxnard Police Department. And so all of our work goes out the window when community hears about that, and there's pictures, it's on social media. And so already, under this administration, our families don't want to re-enroll in Medi-Cal. They don't want to go to CalFresh. They're so concerned about public charge that they're basically retreating. And our community is resilient. I don't want y'all to leave here thinking that we're living under such fear, but this is our reality. We have to think ahead. We have to think of what our future is going to look like and how our decisions now are going to impact whether or not we can stay in this country.
And I'd like to add to that we have had seen around the state, obviously, a lot of people who are even afraid to just go for services because they're afraid that that might be a place where they're detained. They're afraid that there might be some cross-reporting, even though that hasn't happened. There is a tremendous amount of fear. I remember it was earlier in the year where we were hearing that there were raids, for farm workers that were working in agriculture, so they would be there, hiding for hours out in the fields in the heat, et cetera, because, there was a lot of that. So there's a very real fear. But I also want to add to this piece about the resiliency, because one of the things that I've really noticed about a lot of the culturally specific work is that there is a long-standing history of communities of color doing prevention work, and it may look different, but it's embedded in what they do, so they don't really separate, okay, we're doing an intervention, we're doing prevention. It's all connected, and connected a lot to the activism work that they're doing as well. It's really great, and I think a model that can be used for other communities.
And then one last question, and it really, it's directed to Dr. Bailey, but it piggybacks on what Ray had talked about earlier, and that, and also that was included in the issue, and that is how, we have let the narrative about mental health be almost used as a stigma as we really think about this issue. There's a view that it's mentally ill folks who are committing violence, when in fact many mentally ill folks are themselves victims of violence. But it's also in all of the kind of a running thread through all of the papers, this need for mental health services. At the same time, the narrative is, I believe, putting a stigma on folks even going out and reaching to get mental health services. And it's even in terms of providers. We know that even in California, you can't get a license. It's hard to get a license sometimes if you disclose you've had some cases of mental illness intervention. So I'm wondering, Dr. Bailey, if you could talk about that, and I think the stigma around mental illness getting access is particularly an issue that in communities of color has been problematic.
Well, certainly, and all, I think, very tangible points. On the first one, this issue regarding relative risk, I think, is huge. I think our patients, as I pointed out earlier, that they would argue are not substantially much more at risk of harming others, but the negative propaganda, and I think that the narrative you described, I think very articulately, has been a winning narrative for other sides, I think, of this argument that really have a vested interest in continuing of society to have fear of persons who you really should not be afraid of. I think that's a huge problem that we recognize, and we struggle to really, I think, change that narrative in a much more effective and much more positive way. I particularly think that it's problematic because there's just a great deal, I think, of an economic interplay. Guns and their sale and their resale, their availability on the underground market is $1 billion industry, perhaps even more. And it's in part, I think, because there's so much fear of Americans. We have to have somebody to fear, and we're an easy scapegoat. Our patients are particularly. So there's a lot of work to be done, I think, to change that. And we start, I think, with education, I think, throughout, I think, all spheres. You make another point. I think it's also time to decide that if we don't have enough providers or enough support, I think, in this business. I'm a unique entity because I've worked in many southern states, Redden State Hospital, Alabama, from Texas, et cetera. I chaired departments in 2 southern states. So I'm actually happy to be in California. I've actually never been to a place with a $1 billion state budget for Department of Mental Health. LA County has a $2 billion budget for mental health. So I may be the one person who's saying, yippee, I'm finally in a place where there are resources to avail. But you make another point, we have to use them, I think, wisely and effectively so we can be good stewards, I think, of the public dollar. First and foremost, I think we have to hospitalize persons in an effective and a timely way and not abuse that system. I testified for the first time last week in this area, and the rules are very different here. What it takes to actually hospitalize someone who may be at some relative risk of a future violent act. We also, I think, have to recognize the value, I think, of what's called wraparound services. Not only do medications like pharmacology matter, but what we do, I think, after the particular medication, I think matters at least as much, if not more, in reintegrating people, I think, into a system that works for them, work and family and housing. So there's a lot to be done, I think, to limit the risk that individuals just continue to kind of go down that so-called slippery slope and end up, homeless and impaired and unable to function. The final point I think you addressed that I think is also key is we have to find ways, I think, to be interdisciplinary in mental health and psychiatry with other forms of medicine, other areas of medicine. To the extent that we have not done that in some settings, we've actually, I think, missed the opportunity to provide better overall value for the mental health patient.
If I just may really quickly, I just want to add that I think one of the things that we've seen, we did have a federal grant to look at bringing more trauma-informed resources into our model and into the communities we serve. And I think around the stigma that certainly has been there both in the African-American and Latino communities that we serve here in Los Angeles, lots of issues around that, including within our providers, right, who are also folks of color, many of them who've lived in these communities for a long time, experienced violence. They had a lot of their own stigma about getting resources and help for themselves as providers for the trauma they've experienced or the vicarious trauma. I think we've made some headway in opening that up and having them be able to better connect their clients. But we did see, even with very well-respected entities who worked with us on the project, that some of the providers just weren't equipped to not just serve communities of color, but communities of color who've been impacted significantly by violence, and the understanding and connection with youth around the issues of gang or group violence, gang culture, that sort of piece. Quite a disconnect to finding the right folks to connect, to provide the services. And then I'd say lastly, I think thinking of it also as that healing and centered and being more thinking of it more broadly, that there are indigenous practices that have been very powerful and effective. Particularly, we were able to do that in our Latino communities, build on that, and it was tremendously impactful for the providers, the community who received some of those services, the community at large, as well as the youth and families receiving services through one of our contracts. So I'd love to see more investment in exploration of whether it's indigenous or community-based or I don't know what the words are, that's what I'm trying to search for, but ones that really connect, that are really culturally competent and culturally grounded for the communities that we serve. So making sure that we have those practitioners as well as the investment in that will be really valuable.
Hi, thank you. I'm Erin Lanahan, and we've been talking today a lot when it comes to violence prevention, intervention, interruption, and healing. We've heard about a lot at the local and state level, particularly for California, which makes me very, very happy and proud to live here. But thinking about the federal level, where we've seen a lot of retrenchment, I'm actually wondering if there's any good news from your perspective out of the federal level, even in the current climate, and wondering if there are any policies or agencies that you can point to as having a positive impact on your work and with the groups you work with. I know, Anne, you just referred to a federal grant, and so I'm wondering, again, any good news from the federal level that we can point to?
Well, the federal grants that we had were all initiated under the prior administration, and the majority of grants that we work with in the Mayor's Grid Office on the federal level do come out of the Department of Justice. So OJJDP, on the juvenile front, the burn grants, public safety related grants. So we were effective in getting those and developing grant proposals that were focused on public safety, but from a non-law enforcement suppression angle. And so some of those did continue under the current administration, but we have not. We're in the process of working with LAPD right now on a federal grant application that has has both their approaches combined with some of our approaches, and so we'll see where that goes. But that will be the first that we've done as an office applying during this administration. So fingers crossed.
And if I can add, CalCASA sits on a group called the National Task Force to End Sexual and Domestic Violence, and there are a lot of people that are DC-based, and I respect them a lot because it's crazy, the number of emails and the kinds of things that they're addressing and dealing with every day around policy, specifically, violence against women, sexual and domestic violence. And there's been a huge push around prevention. It seemed like it was making some headway, but I think right now with the climate, I think everything's kind of on, I don't know what's going to get done. But there are people that do this all day, every day, and are really trying to help advance or at least hold the line on some things. So, yeah.
So I think we're going to give the last question to Ray.
Thank you, Ray Baxter, Blue Shield of California Foundation. To follow up on this last discussions, there have been occasions when business has led when government hasn't. Sometimes in the health area. The question I have is there any leadership coming from business around this? One of the interesting things to me was in all these papers, there was nothing about workplace violence except for the hospital paper, which had some extraordinary stuff kind of based in it. I mean, if a hospital is not a safe place, what is? But if half of physicians in emergency rooms have been assaulted, often more than once, it's clearly not a safe place. Has there been any leadership other than the fortification of workplaces that's taken place? And is that an avenue to pursue if there's not policy leadership from the national level?
Can I respond to that? Yeah, I really appreciate that question. Because I think we are seeing a lot of people stepping up in terms of the business, particularly around low-wage workers. So one of that I can hold up as a model is actually the union. It's the Service Workers Union, California Service Workers Union out of SEIU, and they have been leading its heavily prevention around policy change, around putting in policies to prevent sexual harassment and workplace violence, changing a lot of their internal rules, and a lot of other industries and other kinds of low-wage workers are looking at that model. So I know their main headquarters is out of Los Angeles here, and it's really impressive, and it definitely is having not just a statewide impact, but a national impact in terms of people looking at what can happen within certain industries and in the workforce.
Other?
I just would say business is going to have to lead. I think it's a very good point. We just unfortunately are at one of those nadir periods where our government now is really very entrenched in this setting. The discussions were remarkably partisan. One of my group actually spoke before a Congress hearing, and it was difficult to even get both sides to kind of sit in the room at the same time and hear a discussion. So I think that the part that's most striking for those in this room is how hard it is to even have an academically oriented, data-based, empirically based discussion about gun reform or gun violence or violence in general. I think because of the overly partisan nature, I think, of government currently at the state and I think the national level. So one would hope that I think business would do so, in part because this has to hurt business. We can't function well if employees are overly afraid and unable to function optimally in a job setting.
Okay, I think this is a good place for us. Before I thank our panel, let me just first of all say many thanks to the California Wellness Foundation and the Blue Shield of California Foundation for the support to make this possible. I don't try to summarize these events because so much was spoken, but I just want to highlight two things. One is I do think we identified a tremendous wealth of policy issues at the local, state, and federal level. All of them came up. They're different. They're complex, but they all need attention. And the second, somewhat related to it, I'm struck by much of what was said today, but I was really struck by the notion that at the higher levels of government, we do tend to do all these divisions: prevention, intervention, perpetrator, victim, research, practice, intervention. At the local level, and particularly drawing from the indigenous experience, there is much more of a holistic sense that these are often the same people going to the same communities, going to the same homes, facing a constellation of issues that go far beyond the violence that may have brought them into the system, and that it's only when you see them all together that you can make sense of this. And so we really need to harmonize these. We need both of them. We certainly need to think of them at a programmatic level, but we also need to bring them together at a community level. And I found that one of many striking elements of the conversation today. So thank you for joining us today, and please, as we close, join me also in thanking our final panelists who brought this all together. And we are adjourned.